Hey guys, welcome back. This is Dr. Marwah, and today I'll be decoding the recently concluded MCA screening test. We'll be talking about questions from the June 2021 exam. So let's offer some solutions from general medicine. The first one talked about a patient who is admitted in your intensive care unit. He created a scenario where you happen to the junior resident on duty and your senior doctor is asking you to manage this patient accordingly. The key words in this question was hypoventilation, and there was a respiratory acidosis developing in a patient, and he said, how would you reduce this carbon dioxide values back to normal? Now, I want to highlight at this particular point of time that if you listen to the emergency medicine section in the app, and that's very important for any exam per se, whether it's be a USMLE exam or an Indian exam, really does not matter. In mechanical ventilation, you will notice that I have discussed two scenarios. In one of them, the patient is having type 1 respiratory failure. You can very well see, and I'm just writing it down for your convenience. In this type 1 respiratory failure, there's a carbon dioxide washout from the body. The primary problem of this patient, that is patient number A shown here, is hypoxia. But if you look at the actual scenario which was asked in the exam, where I'm just pointing at the movement, was the exact replica of what I have discussed. If there is a buildup of carbon dioxide in the body of the patient, how would you kick out this carbon dioxide was the precise question. All you would do in this particular case would be increase the respiratory rate of the patient. If you increase the respiratory rate, what you're doing here is that you're increasing the minute volume of the patient. And once you increase the minute volume, the carbon dioxide values would definitely come back to normal. Now, I'll just go back to the options once again, because a lot of students, they said, sir, we were confused between two options, respiratory rate and FiO2. Well, the hack here is very straightforward. FiO2 has a O2 here, right? So this would be mainly to treat patients who are having hypoxia. Like, let me say you are having a patient of COVID-19 pneumonia with a hypoxia. He is not maintaining his oxygen saturation at the movement at 15 liters per minute. What will you do? You will put the patient on a high flow nasal cannula at 60 liters per minute. So effectively, when you increase the FiO2 of the patient, you will be able to increase the partial pressure of oxygen in the body of the patient. And that is what I've highlighted. Once again, I'm going to go back to the snapshot. This is what I've highlighted. If a patient is having primary problem of hypoxia, the management of that would be increase of FiO2. It's very simple. Oxygen, O2, FiO2 is what you increase. If FiO2 is not going to be in the options, then you definitely can use PEEP as well. So in this MCQ, I'm discussing two MCQs with you right away. And this is one of the very common scenarios in our intensive care unit, that either you have hypoxia or you have a sudden buildup of carbon dioxide. So the strategies will vary. I'll come back to the first slide. The correct answer to this multiple choice question is not A, as a lot of guys initially thought it may be. Well, I just offered you a simple hack. I mean, if you want to increase oxygen, you increase FiO2, the fraction of inspired oxygen, you increase the flow rate of the patient. But if you have to remove carbon dioxide from the body, you are going to increase the respiratory rate. Now let's look at option number C, increase of PEEP. Positive end expiratory pressure. If you increase the PEEP of the patient, it will cause more alveoli to remain open. So I can effectively use the word recruitment of alveoli. And if you recruit more alveoli, if you have more surface area available for gas exchange, you would again be able to increase the PO2 of the patient. So option number C and A both are ruled out right away. Why? Because of the fact that both of them are useful for increasing the PO2 of the patient. Let's look at option number D, increase in plateau pressure of the patient. Well, you definitely can do that, but there is a slight problem in this case, in a sense that because the patient might be having a damage in his lungs, so there is always a risk of barotrauma. I would like to highlight the fact that the plateau pressure per se, whenever you are hiking it beyond a certain limit, it will definitely cause big problems with respect to a possible pneumothorax developing in the patient, which is why option number D is also ruled out and gives credibility to the answer of this multiple choice question as option number B. My humble request to all of you listening, whether you sat for the FMGE exam, whether you're gonna sit for the forthcoming INICET exam, just listen to the mechanical ventilation strategy once at 1.5x, and you would be able to get the scenarios right with respect to the various possibilities or the problems that you can encounter while the patient is on the various modes of respiration, and their disadvantages can also be asked. Let's move on to the second question. This was more of, I would say, a scenario which you will always encounter again in your intensive care unit or in your CCU, the coronary care unit. He said, you are the intern who has observed that the patient has become unresponsive. So you did the right thing by connecting the ECG leads to this patient, and once you hooked up the ECG leads, you found that the ECG was showing a arrhythmia. Now, what do you do for any arrhythmia? It could either be a patient having ventricular fibrillation or it could be a pulseless ventricular tachycardia. So the doctor has done the right thing by delivering a DC shock to the patient. The question said, once you have delivered the DC shock, even then, the arrhythmia of the patient is persisting. That's the key word. You have already given DC shock to the patient, but the arrhythmia is persisting. What would you do next? The first thing that will cross your mind will be, will I deliver another DC shock? Yes, I have to deliver another DC shock, but it will take some time for the machine to charge up again. You see, the patient is already hooked up to the defibrillator. That's okay. Once you press on the button, the machine discharges. It fires the impulse. That's 200 joules biphasic that I've explained. But once the machine has done its job, it will take a few minutes for the machine to recharge once again, and that's when the second shock would be delivered. So in between that time, what are you gonna do? You're gonna deliver CPR for the patient. In fact, CPR should never be discontinued between two shocks. For this, I want to highlight the reference of the ACLS lecture, the Advanced Cardiac Life Support lecture, where I've highlighted, in fact, I have hand-drawn this. I have not shown a simple protocol. I mean, this is the standard American Heart Association protocol, which is already available on the YouTube, and I've shot a video for that. But I have actually hand-drawn this protocol, and this is what it says. He says, if you encounter a patient who's pulseless, you see, he says attached defibrillator, you find that it could be any of the two rhythms. When you fire a DC shock, one here means the DC shock has already been given. The wavy line I have drawn here represents DC shock being administered. Now, before you fire the second shock, there are two things that you do in between. What are the two things? You continue with the CPR for 2 minutes, and second, you have to get a IV access. Now, if next time he gives you a scenario that the second shock has also been delivered and there is no improvement, what will you do? You will again give CPR, and from that IV line, what will you give? Epinephrine. This epinephrine is not for cardiac arrest, right? I have explained that it is for management of ventricular fibrillation. And how will adrenaline work in ventricular fibrillation? Well, adrenaline will cause an increase in coronary blood flow, because it will increase the peripheral resistance. So it is going to contribute to increase of coronary blood flow, and that will reduce hypoxia, which is responsible for ventricular fibrillation. So this is again a very important part of the discussion, or I would say a very standard scenario that they can anyway create before you. And for question number 2, I'm very sure that everybody could rule out bag and mask, because you are at this particular point of time more concerned about circulation. You see, the care of the patient is CAB. Any patient who collapses, it's CAB, circulation, airway, breathing. So I'm ruling out C. Why? Because at the moment I'm handling the C component. Check carotid pulse. You see, the patient is unresponsive and pulseless. If a ECG is showing a arrhythmia, I repeat the fact again. If ECG of the patient is showing a arrhythmia, there will be no pulse. I mean, it's a waste of resources that you have hooked up the patient to a monitor. You have hooked up the patient to a defibrillator. On the monitor, you can see it's an arrhythmia, and you're trying to check for pulse. You won't get any, because these arrhythmias fire at a very high frequency. So C and D are totally out of the window. You're left with two options. That's going to be delivering another DC shock and starting CPR. Now, yes, giving a next DC shock obviously makes sense, but he says, what will you do immediately? The language of the question was, what is the next best step? And as I highlighted to you, you would be giving CPR to this patient at this moment, so that at least the coronary flow and the cerebral flow is maintained, so that you can save neurons. Otherwise, the person would be brain dead. I mean, brain dies within 4 minutes. Coming to question number 3, the question said, which blood vessel or blood vessels are involved in type 2 Takayasu arteritis? For this, I want to highlight that right before the exam, I had posted a video on my YouTube channel, that is MedPath Cardiology. And in fact, that's also present in, the main app also. So it was just the same video. And I would like you to, right now when you're listening to me, just go to 1 hour and 28 minute timeline of this video, which is present on my YouTube channel, where I have talked about the various types of Takayasu's arteritis. In fact, in this particular video, Dr. Sparsh has discussed the histopathology of the slide, and then I've tried to explain regarding what are the blood vessels which are going to be involved in Takayasu's arteritis. I'm just going to hand draw this before you, so that you can just get a better orientation before I come to the branches. So try to draw with me. Let's do it quick. You can see the arch of the aorta. Then I have highlighted blood vessels here. This is going to be the brachiocephalic trunk, right? This is going to be the subclavian artery and the right common carotid. And on the left side I've highlighted is the left common carotid and the left subclavian artery. Now I want you to understand and listen to the pattern very carefully. Initially, and in fact the most common blood vessel that happens to be involved in Takayasu's arteritis is the left subclavian artery. So initially this disease will involve the branches of the arch of the aorta. I repeat the fact once again. Initially this particular disease will be causing narrowing of the ostia of the left subclavian artery. This is LSA, left subclavian artery, and narrowing of the branches of the right subclavian artery. But as the disease will progress, it will also start causing involvement of even the arch of the aorta. So type 1 Takayasu's arteritis is only when the branches are involved. The branches are left subclavian and right subclavian. Type 2 is when you are not only having the involvement of per se the left and the right subclavian, but you're also having involvement of the arch of the aorta as well. So this was a fact-based question. Option A says arch of aorta branches. That's type 1. You just need to keep on going down. The answer to this question will turn out to be beta. You can understand this better with respect to this particular diagram that I've highlighted. In fact, you can very well see that in type 1 Takayasu's arteritis, only the branches are getting involved. But then double A means the ascending aorta as well as the arch of aorta getting involved. That would be type 2, and in fact type 2 would be having two varieties. So I'm just going to call it a type 2A and a type 2B, where you are not only having the ascending aorta but even the thoracic part of the descending aorta getting involved. As you move on inferiorly in type 3, it is descending aorta and the abdominal aorta. I hope everybody remembers that infrarenal abdominal aorta is the commonest site of aneurysm. Right? I repeat that fact again. The infrarenal abdominal aorta is the commonest site with respect to aneurysm that could be developing thanks to atherosclerosis. And today we are talking about pulseless disease per se. And if you're having a uniform involvement, that would be the worst case scenario. I mean, here in type 5, you can see everything getting involved. That's where the pulselessness would come. That's when the femoral artery pulses will be obliterated. That is where you may not be able to, feel the popliteal artery of the patient, and you will obviously not be able to feel the radial artery of the patient because subclavian arteries are getting involved. So just go through this at maybe 1.5 or 2x and just revise regarding the Takayasu's arteritis component, especially the vasculitis component that we have covered is definitely to be remembered. The answer to question number 3 is Bombay. Moving to the fourth one. This talks about which of the following will be showing pulsus paradoxus. So standard causes of pulsus paradoxus are mainly going to be cardiac. That's going to be cardiac tamponade and rarely constrictive pericarditis. But even if a person is having very severe acute asthma, if a person is having a rather a status asthmaticus, though status asthmaticus term is not, I would say, used as of now, then the person could be having pulsus paradoxus. Why? Because then status asthmaticus, he's using extreme amount of pressure to breathe in. So I would mention the fact that why is there going to be a pulsus paradoxus? Because there's going to be an increase of the negative intrathoracic pressure. Now listen to the words very clearly here, because not only am I offering you an answer to a question, but I'm also giving you an explanation per se. I mean, the guy is not being able to breathe. Why? Because of bronchospasm. So he's gonna develop the accessory muscles of respiration are gonna work over time. So there's gonna be a tremendous increase in the intrathoracic pressure. That's the negative pressure. So this is gonna reduce the venous return to the heart. If you decrease the venous return to the heart, then I would say if less comes in, less would go out. So the blood pressure of the patient will also begin to fall. If the blood pressure falls, the pulse of the patient will become relatively weak. And in fact, it might become so weak that it might actually appear to disappear. In fact, that's the point I want to highlight, that the pulse is very much there. It's just that you are not able to feel it. The pulse is very much there, but for you, the impression is as if it is appearing to disappear. That is the paradox here. I mean, the paradox is that pulse is very much there. You see, I'm not teaching you cardiac arrest. All I'm saying is if an asthmatic is very, very sick, you could definitely be having pulsus paradoxus. That's what I've highlighted. If a person is having acute asthma exacerbation, goes into a severe acute asthma, then goes into impending respiratory failure, a definite possibility of pulsus paradoxus is there. And that is what he did in the question. He did not include the traditional cardiac tamponade in the options, and you just had to go by the fact in this particular case. The answer to question number 4 turns out to be Bombay. And as far as the remaining options are concerned, they're relatively easy to rule out. At least I am very, very sure the moment you read this question, C and D are totally out of the window. I mean, you don't need to consider them anyway. Pleural effusion, obstructive sleep apnea do not have anything in the form of pulse disappearing. So you're left with pulmonary artery hypertension. You might be thinking by some freak accident, you might have missed it, but then pulmonary artery hypertension mainly causes a loud P2. It causes a pulmonary oligemia. It causes a exercise intolerance. It causes a right ventricular hypertrophy. The problem in pulmonary artery hypertension is related to the right side of the heart. Whereas when we are talking about pulse, we are talking about the left side of the heart per se. So I would personally feel that this was simply to test your nerves, in a sense that we are, adapted mentally to select from those options that we have read, that is mainly cardiac scenarios. But at the same time, I want you to remember that even respiratory conditions like severe bronchial asthma, tension pneumothorax, even severe COPD, and even possibility of pulmonary embolism can contribute to development of pulsus paradoxus. In fact, even in obesity, even in pregnancy, you could be having a pulsus paradoxus present. So if you just go to the first lecture in let me say the FMG section, I've talked about the various types of pulses, and there I have specially highlighted regarding conditions where pulsus paradoxus can be present. The answer to this question is Bombay, and we move on to the next one. Coming to the next question, it talks about a young patient who's having fatigue and recurrent syncopal episodes. The moment you read that line, I mean, you have to think in terms of WPW syndrome, or it could be recurrent tachyarrhythmias, or it could be bradyarrhythmias. Only three possibilities are there. The Holter of the patient was done and a 24-hour ECG recording snapshot was given. Obviously, they cannot put on up a entire 24-hour ECG file for you to scroll through, so they just gave you a segment of that. The question said, what would be the best treatment of this patient? And what I could recollect from my students was that in between a couple of R waves, there was literally an area where there was a sinus arrest. You can very well see the marked number of large squares between the two R and the R wave. So there's going to be a bradycardia present in this case. And anytime a patient is having a bradycardia, you would require a pacemaker. Now, the query of a lot of students was that, sir, we also found in the same ECG a reduced RR interval also present. You can see I put up a marking. Well, guys, this can be a presentation of a sick sinus syndrome. You see, if the SA node will not function properly, though obviously you have to pick up a P wave for malfunction of the SA node, which is non-existent in this case, you can definitely see a QRS complex, but there is no preceding P wave present. But even if you miss that, I want you to understand that whenever there's a sick sinus syndrome, you could be having a presentation called as bradycardia tachycardia syndrome. This bradycardia tachycardia syndrome, which looks very peculiar when you read it for the first time, is where the heart will tend to compensate for when there was a decrease in the cardiac output that could have resulted in a possible lightheadedness and then a syncope in the patient. Well, guys, the point is, in this particular ECG, because there is a significant bradycardia documented, the correct answer for this patient would be to deliver a pacemaker. That's a permanent pacemaker recommended for this patient. We do a temporary pacing for inferior wall MI, but that's a separate story at the moment. I'm very sure all of you could rule out option C and D here, anticoagulants and antiarrhythmics. I mean, nobody messed up on that. It was only the confusion between A and B that I want you to understand. Implantable cardioverter defibrillator is primarily for only tachyarrhythmias. Those tachyarrhythmias could be conditions of various cardiomyopathies. In fact, I mentioned a mnemonic for that, no? ABC, ARVD, arrhythmogenic right ventricular dysplasia, then Brugada, and then a cardiomyopathy. And this was not satisfying any one of these. So you could have ruled out by deploying this mnemonic per se. And I'll just show you a snapshot also with respect to sick sinus syndrome, where the heart rate of the patient is going to be substantially reduced. I mean, that can definitely be having a situation where the person might even lose consciousness. So you will require a pacemaker for these patients. And the pacemaker lead, I mean, the oldest of the pacemakers, the single lead pacemaker that was introduced way back in 1950, the wire was not going and touching the right atrium, because there was a separate MCQ that I'll discuss separately, where there was a pacemaker shown in an X-ray and a wire was going. That wire will not go and touch the right atria. Because after in the right atria, agree, in the right atria it's SA node. I mean, that's the usual thought process. But after SA node, there is the AV node and then a bundle of his. So if they malfunction, all the hard work is lost. So we do not try to control the right atria. The pacemaker lead goes and touches the right ventricle. The logic is that if you can time the contraction of the right ventricle, you will be able to send blood to lungs. Because what is the function of the heart after all? It is one of the important functions is oxygenate the blood. I don't want to time the activity. I just want to oxygenate the heart better. I just want to oxygenate the blood relatively better. So in a single lead pacemaker, the wire goes and touches the right ventricle. Though we have a dual lead pacemaker also, where there could be two wires going into RA and RV. But for a single lead pacemaker, it's RV that is paced. Coming back to the question per se, I want to highlight that this ECG is of a condition called as bradycardia tachycardia syndrome. And this could be a presentation of malfunction of the SC node of the patient. A suggestion which is mainly for those of you who might be sitting for NEET or any side, because there is still some time, especially for NEET. You see the book Final Edge of Mine. I'm not promoting the book, I'm just telling you very facts. This Final Edge is available on Google Books. And there's no, I mean, it's free of cost, obviously. So you can just type the word Final Edge and then type any of these words: bradycardia, tachycardia, movebits 1, movebits 2, complete out, whichever, and you will be directed immediately by the Google Books to the section where I have discussed these various ECG scenarios. Maximum, there are total of 50 ECGs that you need to go through. And believe me, it might look, very humongous tasks for you at the moment, but just go through it, right? Just spend 3-4 hours on it, and I'll be very sure that you will be having a better insight with respect to very common things that are asked. And primarily, like, this is one of the ECGs that I've highlighted in the book as well. So answer to our question was a pacemaker, and we move on to question number 6, highly debated one. Which of the following will not have this presentation? A lot of guys just looked at this. They found that the patient was having a very characteristic palmar erythema. You can notice that the central part of the palm definitely has some pallor present, but then the thinner eminences and the hypothinner eminences are having a definitive flush. They're definitely having a redness present. This palmar erythema is very characteristically seen in cirrhosis, which is a condition in which the levels of estrogen in the body will dramatically rise. The question was a not one. So cirrhosis is where you will have it. Now, would you have it in pregnancy? A lot of guys said because the hands of the patient given was an old patient, then how can an old patient have pregnancy? See guys, they gave you this image of a lady, old lady, not because they want you to find whether she is pregnant or not by looking at her hands. They are giving you the hands of an old lady to pick up a finding, not to tell what is the age of the patient primarily. Pregnancy also has elevated estrogen. And those of you are saying, no, sir, we have read in OBGY that pregnancy mein progesterone is elevated. How can you say estrogen is elevated? Look at this chart, man. After fertilization, not only will you be having an increase in the value of HCG, not only will you have a rise of progesterone, but even estrogen will rise. In fact, I would like to tell you the fact that in women in whom estrogen rises more in the first trimester, they tend to have more vomitings. Remember, you study about a disease, hyperemesis gravidarum. Hyperemesis gravidarum is related to more estrogen in the first trimester of pregnancy. And you would also know that women who are relatively obese have more estrogen in the body. So you will notice that rather obese or chubby patients could be having higher incidence of hyperemesis gravidarum as compared to skinny or thin patients per se. But at the moment, I want to tell you that estrogen values definitely increase in the first trimester. Then they'll obviously decrease, as you can see. So yes, you can definitely be having a palmar erythema present even in pregnancy. When it comes to rheumatoid arthritis, the logic is rheumatoid arthritis is more common in females. Autoimmune disorders are more common in women, and women will be having a higher value of estrogen. So if you look at the situation here, there are 3 conditions which are having more estrogen in their body and palmar erythema present. The option by exclusion will turn out to be option number delta, that is a hypoestrogenic state. I want you to understand the fact that this particular condition, I mean, common error which a lot of my students did was, ki sir, we just looked at it, I missed the not word and I answered it as cirrhosis, and some people marked it as rheumatoid arthritis. To usme your logic I explained, right, that rheumatoid is more common in women. They would be having a higher value of estrogen. So you just need to get this fact right, and I agree that 6th was a little tricky one. I would say that there could be a error of judgment that could be present while answering this question. So yes, I would say that this was relatively a question which they deliberately wanted to twist your mind per se. And this is a table which is mentioning the primary and the secondary causes of palmar erythema. So you get it with the higher estrogen values. It could be liver cirrhosis, rheumatoid infections, atopic dermatitis. And I mean, you don't need to cram the list per se, but at least these three causes, the important ones that I mentioned, should definitely be remembered. Moving to the next question. Going to question number 7, this is about a 30-year-old patient who's having breathing difficulty on day-to-day activity, and the physician has noticed dullness to percussion. At the same time, there is reduced air entry. So the moment you read about reduced air entry, you're thinking, is it a pneumothorax or is it a pleural effusion? And you very well know the fact that when it comes to pneumothorax, there should be a hyper resonant percussion node, because it is written dull in this case. Ideally, it should be written stony dull, but even if it is dull and a reduced air entry, you're thinking in terms of pleural effusion, which he has simplified by himself mentioning it in the question. The question that mentioned the thoracocentesis of the patient was done. Which of the following findings will suggest it is an exudative pleural effusion? What you had to do in this question is deploy the Lights criteria per se. And now I'll just show you the snapshot of the Lights criteria that I've discussed. The two components of the Lights criteria are protein and LDH. Please remember the fact, and I've used a separate color to highlight that sugar is not a component of the Lights criteria. Based on this information, we go back to the options present in this case. Now look at the jargon that he put in. He gave you combinations of protein with LDH, protein with sugar, sugar with the protein per se. I want you to understand that options which are having glucose have to be ruled out immediately, because glucose is not a component of the Lights criteria. People were, I would say, flabbergasted. I'm using a sophisticated or a longish English word, flabbergasted by the values which were given. All you had to do in this particular case was evaluate whether you are having two things present simultaneously or not, that is LDH and pleural fluid protein. And suppose you say that there were two options, right? I've just put one for your convenience, which is option number A. The next thought process of yours is that in Lights criteria there are two things that I mentioned. One is going to be the protein and second is the LDH value. All of you know the total serum protein, and if you don't, I'll just mention that before you. Normal total serum protein, that is combination of albumin and globulin, is 6 to 8 gram percent. Take an average of 7 gram percent, average 7, right? And if in the pleural fluid, now remember my words carefully, if in the pleural fluid this protein is more than 0.5, that's what I showed in the previous slide. I had written values of more than 0.5. If in the pleural fluid estimation the value is more than 0.5 of the total serum protein, equal to or a little more than that, it is suggestive of exudative. This value is given to be 3.5 now. 3.5 is about 50% of average of 7. So that definitely satisfies the criteria. And how much is the serum LDH values? Now I don't expect you to remember all the laboratory values, but because now we are solving the paper, I want to tell you that the international units, the serum LDH is something in the range of 140 to 280. So you can take an average value of 200 and here it's given to be about 100. So I can say, okay, fine. I mean, this goes slightly in favor of exudative because two components are being satisfied, proteins and LDH. And in the exam, believe me, they did not expect you to do calculation that, okay, is protein more than 0.5? They did not expect you to do, okay, is LDH more than 0.6 of the total LDH, and they expect you to know what is the serum LDH. No, they're not expecting that. All they expected was that you should be aware of the fact that in Lights criteria, sugar or glucose is not considered. When it comes to low glucose, there's a totally separate discussion that I've had. Obviously, you could be having empyema, you could be having rheumatoid arthritis, you have to think in terms of malignancies. But per se, when it comes to exudative, those are the criteria which I've highlighted. And I'll just say this once again, that please go through these diagnostic criteria. I mean, for every disease in medicine, the main diagnostic criteria that are summarized, they are the ones which are usually asked. And the same can be done for ascites next time. I have discussed regarding SAG, serum albumin ascites gradient, more than 1.1, less than 1.1 for transudative versus an exudative. I mean, we don't use the word transudative and exudative with respect to ascites, but SAG gradients are again something that have been asked in any set, and in your exam they asked about the pleural effusion component. In fact, this kind of a question was even present in the last time's paper, and this I would say is just a replication of the same. Now coming to the next question, he talked about comment on the position of the pacemaker lead. So you can see a single lead in this particular case, and as I've highlighted, a single lead pacemaker will be controlling the right ventricle. The objective is to send blood into the lungs. It's not about electrical control, it's about mechanical control. I repeat that again, it's not about securing an electrical control, it's about securing a mechanical control so that the basic function of the heart is achieved. And the latest pacemakers that are available at the moment are called as triple lead pacemakers. this would be having three wires that would be going up to the right atria, the right ventricle, and then it's going to be the left ventricle. Why not control the left atria? Because left atria will automatically behave itself, because pulmonary blood flow will flow into the LA of the patient. So we don't want to waste computing power, because if you are going to add, I would say, controlling or try to control the left atria of the patient, it would be wastage of the computing power and it would be wastage of battery also. So I would say that they have used smartness in a sense that they are only controlling those chambers that really matter. The answer to this question is option number C. We move on to the next one. This lab shot I have already highlighted with respect to the permanent pacemaker site. And I also want to tell you that the temporary pacemaker can be put in inferior wall MI. In question number 9, this would be a combination of medicine and physiology. There were two curves that were given, and for your convenience, I have already, interpreted the two before you. But I want to highlight like this, that you very well know that in the spirometry curve, you would be having a tidal volume, and then you will ask the patient to fill up max amount of air into his lungs. That would be going up to the total lung capacity, and then ask the patient to breathe out. Now, when the patient would breathe out, you would ask him to breathe as hard as he can, right up to the end of, listen to the words carefully, right up to the end of the expiratory reserve volume, because whatever air that will remain at the end of a forceful expiration would be the residual volume. Now, when it comes to obstructive airway diseases, I'm just going to sketch this once again before you. In obstructive airway diseases, you have asked the patient to breathe in. Inspiration is fine, because asthma, COPD are diseases of expiration, so there's going to be a prolonged expiration. So you will notice that this curve, instead of falling like normal, the curvature of this curve would be relatively increased. Why? Because it's going to take relatively more time. So I'm not sure about the fact that whether they mentioned the word normal versus COPD in the exam, but the bottom line is, if you get a curve in which the expiratory time, that is right from the peak of total lung capacity, you have told this guy breathe out as hard as you can, and this guy is taking more time, that's an obstructive airway disease. At this junction, the query in your mind would be that, sir, how would restrictive lung disease look like? In restrictive lung disease, this total tidal volume will also be lesser, because there is pulmonary fibrosis. And overall, I'm just going to draw a smaller curve here, and I would rather say that the fall will be relatively faster, because this guy is anyway having lesser capacity. So if there's less air, that less air will go out faster also. So the curvature part would be lost when it comes to a restrictive airway disease. Before I comment on the answer to this question, I just want to show you that there are two curves that I've highlighted in this case. One is for obstructive airway disease. In fact, I can just mark it here before you. There's a shift of the curve. You can see the curvature coming up. That's obstructive. When it comes to restrictive, the slope becomes relatively lesser. The curvature slope would be relatively lesser. So once you get this in your mind imprinted, our next job would be to get the question right. He said, which of the following is not correct? Option A says reduced forced expiratory volume. Yes, we do get a less FEV1 in obstructive airway disease. Increased residual volume. Yes, because there is air trapping. One of the characteristic features of both COPD and asthma is a air trap. So A and B are definitely correct. We have to select between C and D. Increased timed vital capacity and reduced vital capacity. Timed vital capacity is a ratio. It's a ratio of FV1 divided by FVC. And if you have listened to the spirometry component or the flow volume curves per se, this ratio is always reduced in obstructive airway disease, whereas in this MCQ it is written increased. That's the wrong statement in this case. So the answer to question number 9 will turn out to be option number C, and the remaining options are fine. Vital capacity is lesser in patients, because vital capacity would be a sum of the top three. That is inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume. And because in an asthmatic there is an expiratory disorder, so therefore ERV can be lesser, so therefore the total vital capacity will also become lesser. If you just go through the flow volume curves that I've discussed, you would be able to interpret this, though this exact diagram may not be available in routine books. I would say like that, most of the apps or anywhere else this may not be present, though I deliberately went into Google Scholar and I found this diagram, and then I confirmed with my students and they said, yes sir, this was the kind of a diagram that was given. And I'm very sure that this has not been discussed anywhere till now. So the answer to this question is C, and yes, just a new interpretation, I would say, a new way of asking the old thing. I would put it like this: old wine in a new bottle. I mean, that's how they have just put it. They've just changed the diagram. I mean, in previous exam, they asked a flow volume curve, the traditional thing that we see in clinical medicine, and I've discussed that in the rapid revision of physiology as well. Moving to the next question, easy one and has been discussed by the pathologist as well. A patient presented with chronic diarrhea. So the moment you read that, you know the fact that you're dealing with malabsorption syndrome. It could be celiac sprue, it could be tropical sprue, and then you can notice the nails of the patient which are relatively whitish, and you can notice a characteristic coileonychia coming up. So the moment you read this kind of an information and the hemoglobin is also low, he's saying what is the best treatment for this case. So in patients of malabsorption syndrome, when it comes to tropical sprue, we do not use doxycycline. I mean, why answer is not C and D? We use metronidazole for small intestinal bacterial overgrowth. If you go through the discussion of malabsorption syndrome, SIBO is where we are going to talk about metronidazole, and SIBO involves the terminal ileum. And if terminal ileum is involved, then the B12 of the patient will become relatively lesser. As a result of it, there would be a development of macrocytic anemia in the patient. But what is the point against, I mean, B12 malabsorption in this particular case is the fact that there is no mention of any neurological findings like damage to the dorsal column. There's no loss of proprioception. There is no Romberg sign that is given in the question. There's no neurological findings. And most importantly, coileonychia would not be present. So we are just keeping this pretty straightforward. This would be iron deficiency anemia courtesy malabsorption. And for management of iron deficiency, our answer would be iron supplements for the patient. If he had not included this diagram per se, then the answer could have been, any one of these. But since he has given particularly an image related to the classical finding of anemia present in these patients, first of all, we would be going in for correction of the anemia of this patient. Moving to question number 11. A person opens eye to pain, and at this moment I want to say for Glasgow Coma Scale, though this is discussed in surgery as well, please go to the clinical essentials part, and I've shot a video with an alcoholic patient. I deliberately called a young guy, and you will notice that in that video he's slurring. You will notice that in that video he's being abusive. And I deliberately have shot this video with a patient like this because I wanted to show to you the real-time scenarios. That when you are going to talk to a slurring alcoholic patient, how are you going to yourself feel like when he's going to abuse you? You will notice the patient using cuss words in that video per se. I'm just showing you a snapshot. This is me in the white lab coat. That's my patient, and it's present in the app in the clinical essentials component. And I have highlighted especially the motor response, because lots of guys I have seen, they mess up between the word flexion, abnormal flexion, abnormal extension. I repeat the fact once again. You have different scores available for flexion, and abnormal extension, and I've described that the patient is doing those actions of a normal flexion versus abnormal extension, and I would like you to go through that video, please. The question says patient is opening eye to pain, so the solution for this would be eye opening in response to pain would be a score of 2. When you say inappropriate words, P alphabet is coming up 3 times, so that would be V3, P alphabet 3 times, that's how I've explained it, V3. And for the motor activity, the key word was abnormal flexion, because if the question mentioned the word flexion, everything would change. So suppose if you're saying to me that no sir, abnormal word was not there, then the answer will be A. So you need to be very, very particular, and at the moment you don't need to bother about whether you got this right or whether you got it wrong, because in the exam you have to read the words very carefully. I mean, your focus on the screen has to be such that you are able to optimize your output. Because it is abnormal flexion, that would be a score of 3 in this case. That will make the answer to this question as Bombay. And as I've highlighted, please go through the GCS discussion, though the surgeon has discussed it beautifully, but do listen to how in a real-time scenario would you be handling a abusive patient. I mean, half the time our patients are anyway abusive. Just look at the way that guy is responding to me, and you would get an idea regarding the kind of pressure situation that you will have to handle in the hospital. Moving to the next question for today. This talks about a guy having multiple episodes of vomiting, and then is asking you the blood gas derangement. Easy question. Any person with vomiting will be having dehydration. Let's crack this in next 30 seconds. Dehydration will contribute to circulating fluid volume being lesser. You see, after all, there is fluid loss, so there's gonna be loss of water from the body. So circulating fluid volume is depleted, and well, this will cause a positive stimulus to the RAS. This is going to contribute to increase in the values of aldosterone. And now we will focus on what aldosterone will do, and that's the key thing here. Aldosterone will act on its receptor. That's what is called as ENaC, epithelial sodium channel. It will definitely help in gain of salt and water. Why? Because I want to correct the dehydration. This is good news. But the bad news is, and I'm using a different color to highlight, there's going to be a urinary loss of potassium. So you get a hypokalemia. And because there's a urinary loss of hydrogen, so you have is a metabolic alkalosis developing in this patient. In fact, I'm very sure that most of you would not have required all this algorithm and logic to be worked up. The moment you read this word, as I've highlighted so many times, vomiting in a chap, the first thing that should come in your mind is metabolic alkalosis, and the treatment for this is normal saline. This is a hypokalemic metabolic alkalosis. Moving to the next question for today, that's the snapshot of what I've discussed already in the app. The question said the patient is having a pH of 7.2 and a PCO2 68, so both the arrows are going in opposite direction. Whenever pH and PCO2 arrows go in opposite direction, it means it's a respiratory problem. If arrows go in same direction, metabolic. In a respiratory problem, you don't need to even look at the value of bicarbonate. You very well have the answer before you, because the pH of the patient is lesser. This is respiratory acidosis in the patient. Now there are so many respiratory acidosis options given. So you need to look up some logic. The logic is like this. Whenever carbon dioxide increases in the body, it causes generation of protons. And what do you need for neutralization of protons? You need bicarbonate. If bicarbonate will rise thanks to the kidney, if the bicarbonate will rise, we will say this is partially compensated. If bicarbonate is normal, it will be uncompensated. I repeat the fact once again. If at the moment bicarbonate values normal is 22 to 26, if the values given in the question are within this range, we will say compensation has not started, uncompensated. But if the values are higher than this, compensation has kicked in. Thanks to the kidneys will increase the reabsorption of bicarbonate, and bicarb will neutralize the protons. So in this particular case, you can notice that the bicarb values of the patient are on the higher side of normal, considering I would say, like, at the moment they have not gone beyond the upper limit. They're still within the normal limits of the patient. So we will say that the patient is having an uncompensated respiratory acidosis. If suppose in the same MCQ, I'm just doing an ink change here so that you can just get the orientation right. Suppose you say to me that no sir, in the paper the value of bicarbonate was 28, then the answer will change. Why? Because now the kidneys have kicked in. They are like elder protective brother. The elder brother says, okay buddy, I'm going to protect you, I'm going to upgrade the bicarb values. As the result of which, therefore, the answer will change into partially compensated respiratory acidosis. The answer to this question is alpha, and almost a similar kind of values. You see, pH 7.3, PCO2 68, bicarb 28. I mean, that's what I've highlighted even in the ABG section in the app. So if you get time, especially for if you are planning to prepare for your higher exams, do have a look at it. The fourth question is pharma/medicine. This is a 24-year-old lady. She's having a prosthetic valve in place for mitral stenosis, and she's in the first trimester and she's already on warfarin. You very well know that this would be a disaster in making, because the fetus will be exposed to warfarin and you could be having a fetal warfarin syndrome. I mean, there could be problems with development of the child with respect to the limbs. So in these circumstances, I definitely need to stop warfarin in this case. Option A says advise MTP. I mean, she has the right to be a mother. I mean, you just can't tell somebody that you are having a heart valve, so you can't be a mother. After all, we put in a heart valve now. So she can definitely be a mother because mitral stenosis has been corrected. Continue warfarin. I already explained to you that's going to be disaster in making. So we need to switch her to heparin. And well, option number D does not make sense, because even if you give vitamin K at this juncture, it will not have. Suppose this scenario given in the question was for the third trimester. Suppose he said in the third trimester she is already on warfarin. What will you do? You'll continue warfarin and give vitamin K. Why? Because if warfarin is continued in the mother in the third trimester, then baby can develop hemorrhagic disease of newborn. Just for reference sake, I want to highlight that if this question was per se for the third trimester, then your answer will change. Why? Because of the fact that warfarin intake by the mother can definitely contribute to the fetus ending up with early onset hemorrhagic disease of newborn. To prevent this HDN, hemorrhagic disease of newborn, from developing, vitamin K can be added. So the answer to this question is option number Calcutta. And as I explained, I mean, option number D is if this was the third trimester. And in second trimester, there is no need, because at the moment, I mean, she'll continue on warfarin only. First trimester, heparin. If she's not okay with injections, you see, first 12 weeks, injections are on once a day. Low molecular weight heparin subcut. But if she says in second trimester, no doc, taking injection every day is a hassle, no problems. You can definitely go ahead with the tablets as well. 15th, I personally feel was one of the easiest questions of general medicine. There was an x-ray of the patient ankle joint of a diabetes mellitus patient. He himself mentioned diabetes mellitus and ankle joint, where you can definitely notice soft tissue swelling, right? That's very easily visible in this case. And at the same time, you can also notice deformities, right? And you can also notice in this case damage to the bones. At least the I would say the bone density doesn't look to be normal. It looks like maybe they had fractured once and maybe they could be healing subsequently. So there is a disease so deep-seated that it has even caused deformities. That's a feature of diabetic neuropathy, and that results in development of Charcot joints. So the answer to this question turns out to be C. And in the previous years in the exam also they had mentioned that in diabetes mellitus which joints would be involved. So it is mainly the small joints of the foot that would be involved. The X-ray is obviously a lateral view of the ankle in which you can visualize the small joints, but I want to highlight that per se if they ask you in Charcot joints and diabetes mellitus which are the joints that are involved, answer is not ankle joint. The answer is the small joints of the foot that would be involved in this case. So the articulation between these joints, including articulation of the phalanges, are the ones which could be affected, and these patients could be having even a non-healing ulcer in the sole of the foot. The answer to 15 is Calcutta. Coming to the next question, very interesting. He mentioned about a boy. The age is obviously disputable. It could have been 12-year, 22-year-old boy. But we'll talk about the standard history. Recurrent falls with difficulty in ambulation. Now, what I'm mentioning next will definitely be, contended by a lot of you. But I think everybody is agreeing to the fact that our first thought process on reading this question was Duchene's muscular dystrophy. Every time you read a question on a boy who's having difficulty with his gait, if he mentions waddling gait, if he mentions a Gower sign, if he mentions pseudo hypertrophy of the calf muscles, you know it is it's a Duchene's muscular dystrophy. But in the image in the exam, when I interacted with my students, what they told me categorically was that, boss, there was no hypertrophy of the calf muscles. On the contrary, there is rather a calf muscle atrophy. I repeat the fact once again. There was no hypertrophy of the calf muscles, rather there was a peroneal muscle atrophy. And you can definitely argue, sir, we will not able to identify the atrophy. I mean, there's no way by which we can measure in the exam and say it is atrophy versus hypertrophy. I agree to that. But one thing is very clear, hypertrophy would be like Ronaldo's calf muscles, like Messi's calf muscles. I mean, a footballer's calf muscles look very toned. In fact, just look at this image. That will make it much more easier for you to comprehend. I mean, in Duchene's muscular dystrophy, you were supposed to have big calf muscles, something like a footballer's calf muscles. And if you compare this with the image on the top, this is peroneal muscle atrophy. The answer to this question is not Duchene's muscular dystrophy, as a lot of people thought, because he also mentioned elder brother is having the same history. Well, guys, the answer to this question with peroneal muscle atrophy is Charcot-Marie-Tooth disease. The pattern of inheritance of Charcot-Marie-Tooth disease can be autosomal dominant, and autosomal dominant can be expressed in every generation, and brothers and brothers sister can also be involved. So he was just trying to see in the question per se, your presence of mind with respect to the fact that was there a hypertrophy of the calf muscles or not. If it's not, do not answer Duchene's, as I explained it to you. And these are the images that I've actually shown in the app. Both of these images are given. You can see simultaneously, I have mentioned regarding pseudohypertrophy of the calf, I have mentioned regarding peroneal muscle atrophy, and yes, there is also contractures in the foot of the patient, which most of the people said, sir, we were not able to make up any contractures. So the images may not be exact as what actually came in the exam, but you need to get the gist of the question. You need to understand the concept behind the question. Answer to 16 is Bombay, guys. Why? Primarily because of the fact that this would be autosomal dominant condition, and this is actually a congenital neuropathy. Dystrophy, Becker's is XLR, but Charcot-Marie-Tooth disease can be autosomal dominant as well. The next question talks about a 5-year-old boy who is having ultra flexible fingers and can even touch the back of the hand with wrist extended. I mean, Hyperextensible joint hypermobility is the keyword. I'll just show you a couple of images before we narrow down to the diagnosis in this case, and I think it's easy this time. You can notice, I mean, you can try this on yourself. I mean, you try to extend your thumb, no, you would never be able to extend it right up to your wrist joint, but see, in this case the person is able to literally bring his thumb very close to the wrist. Then on the soles of the foot you can see the hyperextension that is possible. So hypermobile joints is a very classical presentation of rubber man syndrome, and rubber man syndrome would be Ehlers-Danlos. For Marfan syndrome, well, what is ruled out is Marfan will basically talk about arm span more than the height. I am ruling out option number A and C because both will begin by a very tall patient. Here he is talking about a kid. He is not talking about a very tall adult. He's not talking about somebody with an arm span more than height. He's not talking about a person who's having a aortic dissection or aortic regurgitation. He's just saying hypermobile joints. And Alport syndrome, well, there has to be a family history of chronic kidney disease. There has to be family history of sensory neural deafness, a lenticonus in the patient. So I think everybody could rule out A, B, C. That's why I called this one easy, because we usually study Marfan at least very well, and Alports as well in pathology very well. And out of C and D, I think you could have narrowed down to the diagnosis of this question. The next question talked about vitamin D deficiency rickets. So without looking at the options, I'll just give the solution. In this case, nutritional rickets is due to dietary deficiency of vitamin D3. If vitamin D3 is going to be less in the body, then calcium will be less, and because of calcium there is going to be increase of PTH. And what will PTH do? PTH will cause loss of phosphate from the body, so phosphate will go down. These are the traditional laboratory reports which have been asked time and again. I mean, in previous years in rickets, they were giving an X-ray, the standard splaying, cupping and fraying that you see. This time he gave the blood picture of the patient. Any patient of rickets will be having low calcium. So you can pick up two options with low calcium, B and D. You need to work out anytime there's a low calcium, the PTH values will begin to rise, and there's going to be low levels of vitamin D3 as well. The correct answer will work out in this case to option number beta. And you just need to understand that every time rickets is present, calcium and phosphate both are going in the same direction. If you will notice in the discussion of internal medicine, calcium and phosphate always go in opposite direction. The only scenario where calcium phosphate go in the same direction is for nutritional rickets. Answer to 18 has been solved. We look at the next one. This is a male patient who's come to you with fatigue, limb weakness in the evening. The highlight of this question, though, has been discussed even by the pharmacologist, but the thought I'll just highlight is diurnal variation of weakness. I mean, in no other neurological illness will you ever read about diurnal variation of symptoms. The symptoms, if they're present, they would stay put. I mean, neurological illnesses are, I would say, severe, and whatever manifestations are there in the morning would be present in the afternoon, would be present in the evening. But two neurological disorders where you get a variation is myasthenia gravis and Lambert-Eaton syndrome. Now, considering that this is not a female patient, well, you need to understand that myasthenia gravis after usually 40-50 years of age is more common in males. In younger patients, 20 to 50 year age group, I would put it like this, the disease is more common in women, but as you go up the age ladder, the incidence tends to reverse with respect to males being affected more as compared to females. Plus he also mentioned that edrophonium was administered and the patient is showing an improvement, so that helps you in narrowing down the diagnosis of this patient as myasthenia gravis. Amyotrophic lateral sclerosis is what Stephen Hawking was suffering from, and you would be having both features of lower motor and upper motor in a single patient. In previous years in your FMGE exam, in the clinical oriented patterns that have come, they have asked about this scenario also of Stephen Hawking that I've discussed in the discussion of channelopathies per se in the app. The next question talks about a patient who is having steroid resistant nephrotic syndrome, and traditionally they've asked about drugs for management, but this time they asked the definition. So I would just like to remind you the fact that in minimal chain disease, we always use the term steroid responsive nephrotic syndrome. The total duration of treatment happens to be 8 weeks. For the first 4 weeks, you would be giving it once a day. And for the next 4 weeks, you are going to be giving steroids alternate day therapy. Now, you are not going to wait for total of 8 weeks and then decide whether somebody is going to be responding to steroids or somebody is not responding to steroids. In majority of cases, we tend to get remission within 14 days, that is 2 weeks. Now, what do you mean by the word remission? The meaning of the word remission when it comes to nephrotic syndrome is that, let me say, day 14 has passed by. Now we're talking about day 15, 16 and 17. So I repeat that again. My 15, 16, 17 here imply day 15, 16, 17 of admission of the patient or of the follow-up of the patient. In the morning, in all of these patients, in the first morning urine sample, we tend to check for urine proteins. And what's happening in this case is when we check for the urine protein per se, for the previous 14 days, the report was saying 3 plus proteinuria, 4 plus proteinuria, or maybe 3 plus, 4 plus, then 2 plus, then 1 plus. But now for 3 consecutive days, listen to my words carefully. If for 3 consecutive days, there is going to be trace protein present, and this usually happens after 14 days of starting steroids, we say person has had a remission. But if this remission does not occur, in spite of giving steroids on a daily basis for a duration of more than 4 weeks. I repeat my facts once again, get the facts right. What do you mean by the word remission? There is trace protein or nil protein in the urine for 3 consecutive days. 3 consecutive days. But when do you say the word resistant per se? You will say the word resistant when 4 weeks have passed by and still there is a proteinuria present of 2 plus, 3 plus or 4 plus magnitude depending on the severity of the disease. The answer to question number 20 is alpha. And I have highlighted and also attached in this case these definitions of remission versus relapse versus steroid dependence. And anyway, the PDF of this will be available in my Telegram group, that is Top Educator. So you can just enroll with that and you will be having access to multiple useful PDFs for your forthcoming exams. The next question talked about a patient admitted with a blood sugar of 350. There's definitely a dehydration because so much of sugar will suck out the water out of the tissues, and there are ketones detected in the urine of the patient. So whenever you have high blood sugar, you have ketones, you are definitely dealing with the case of diabetic ketoacidosis. Now, when you look at the electrolytes of this patient, the sodium is 130, which is on the lower side of normal, hyponatremia. Understandable because sugar will draw in water and the water will cause dilution. And when it comes to potassium, it's about 3.8. So it's a little more than the lower limit of normal. So fine. Now he mentions this very critical statement that I discussed with my students, and I'll highlight it. He says the patient is on insulin but stopped due to personal issues. Now, I have highlighted this in the discussion of diabetic ketoacidosis, that why is ketoacidosis triggered? Like, for example, if it's a child with type 1 or an adult with type 1, because type 1 can occur in all age groups, you very well know that. I mean, age is not a criteria. If a person has gone on a holiday, or let me say due to lockdown, insulin was not available because the chemist shops were shut down for a duration, for a variable part of the day, so parents could not procure it. So if insulin is not given to a insulin dependent patient, then there would be insulinopenia, and insulinopenia will cause burning of fat. That would cause production of ketones. So he says, what should be added to the saline of this particular patient? Well, guys, the point is, in all of these patients, we first give a insulin bolus. I'll just zoom it in. We give a insulin bolus and then we give a insulin drip. The answer to this question is straightforward. We will give insulin to this patient because that's the treatment of choice for this patient, and insulin drip is how it is administered. I mean, initially we give bolus, but then we give infusion. Now the query in this case from a lot of you would be, sir, why the answer cannot be potassium chloride? Because we have read whenever you give insulin to the patient, there will be deficiency of potassium. Yes, that would be a second step. No? The second step would be, because I know when I'm giving insulin, there would be anyway be a deficiency of potassium, I will add potassium chloride to the fluid of this patient. And what is the fluid to be used in this case, guys? It is normal saline that he has already given you, but sometimes ketoacidosis can occur even with the sugar in the range of about 200 to 250. If you listen to the discussion in the app, I've highlighted that in diabetic ketoacidosis, listen to this, or you can see it on the screen at the moment. If the blood sugar is in the range of 250, then you are going to give 5% dextrose in spite of the fact that it is diabetic ketoacidosis. That's again an important point that you need to understand. The primary management of this patient would be an insulin drip. I mean, the treatment of choice for diabetic ketoacidosis is the insulin drip. And suppose you tell me, no sir, the potassium was 3. Suppose the potassium was 3.5 or anything lower than what is normal. My point is, one, the values can be lower. Why? Because there is a dilution in the body because of water. So total body potassium may still be normal. It may not cause an immediate threat to life. I repeat the fact once again. Total body potassium would still be normal at the moment. So it will not cause an immediate threat to life. The first step, that's what the question was asking you. What should be added to saline? So first treat the disease. Then treat its manifestations. That's the basic dictum. No, you treat symptoms, you treat a disease, and then you treat the manifestations of the disease. So here the disease diabetic acidosis would require an insulin drip. Answer to this question works out to be Bombay. And we move on to the next question, which was again a very debated one. The person had presented with multiple episodes of vomiting with obstipation. Now, the moment you read obstipation, you very well know it could even be a large bowel obstruction, it could be a small bowel obstruction. But because he is talking about vomiting, we are thinking primarily in terms of a small bowel obstruction. But now there are two aspects, proximal and distal, both given in the options. So let's resolve it. The X-ray of this patient showed multiple air fluid levels. You can very well see in the central part. So the moment we read that, you can see the jejunal loops in this case, we know it is a small bowel obstruction. Now, should I answer proximal or should I answer distal? The point is, if it is going to be a proximal one, a lot of you said, sir, because it was vomiting, I answered proximal. Think logically, if it is going to be a proximal obstruction, will you have so many air-filled loops? Suppose the obstruction is in the duodenum of the patient. Suppose it is in the distal part of the duodenum or even in the starting of the jejunum, the proximal part, right? You would not have multiple air-filled loops. Therefore, considering the fact that in the X-ray there were so many loops present, it looks like distal. Now, even if you're not satisfied with this, I'll tell you that in India, tuberculosis of the GI tract is so common and can cause a subacute or acute interstitial obstruction. And tuberculosis occurs where? In the terminal ileum. If you have obstruction in the terminal ileum, that is when the jejunum would all bloat up and would all get dilated. So this is, guys, a distal small bowel obstruction. I did had a lot of people, and on Facebook forums different answers are given, like a proximal small bowel obstruction. Guys, if it's going to be proximal, yes, it will have vomiting, it will have obstipation because nothing is going to go in the front. But then in a proximal small bowel obstruction, there will be very minimal air fluid loops, and that too would not be in the central part. The way they clustered all together, this is all jejunum, which is all bloated up, primarily because the person was having a problem in his terminal ileum. And tuberculosis is so common in India, I'll put it like this, that even if I'm not aware of proximal versus distal, whether it's going to be central, whether it's going to be multiple, whether it's going to be scanty, tuberculosis is so common in India and it involves the terminal ileum that the benefit of doubt should always go to option number beta, a distal small bowel obstruction. If I was you and I did not know how to interpret this X-ray, I will still mark as B, primarily because of that I know GI tuberculosis involves the terminal ileum. That would be my take on this. Moving to the next one. A 25-year-old male alcoholic patient underwent a thoracic surgery, and then he talked about inhalational anesthetics being used, a neuromuscular blockade being used in the patient. And during surgery, he is mentioning that there is a cardiovascular collapse of the patient. Now, why do you have cardiovascular collapse during surgery? One of the important reasons for this could be that anesthetic drug overdosage has been given. Because you very well know the fact that all anesthesia drugs cause a vasodilation, so that can cause crashing of the blood pressure. So that would be the first thought process of even the anesthesiologist in this case. But then when you auscultated the patient, there was a decrease of breath sounds on the right hand side. So possibly due to the peak plateau pressures, the peak inspiratory pressures, one of the lung has popped off. And anyway, the person was undergoing a thoracic surgery. So the combination of maybe the workup done by the surgeon, the operative process being done by the surgeon, and high inspiratory pressures being maintained by the anesthesiologist, the lung has popped off and there's a development of tension pneumothorax in this case. ARDS is anyway ruled out. Why? Because ARDS is usually seen after sepsis. So post-operatively, I could have thought of ARDS. Why not cardiac tamponade? Because there is no information suggestive of Beck's triad given in this case. There's no mention of any muffled heart sound, so it's off the radar. Between the two possibilities of atelectasis and tension pneumothorax, atelectasis usually occurs again post-operatively. The basal lung segments will tend to collapse. Or another possibility is the endotracheal tube will slide into the right bronchus. So the left lung will become underventilated, but even that could be a possibility in this case. So yeah, atelectasis I'll definitely consider as one of the possibilities. It could be collapse of one whole lung because the endotracheal tube has slided more into the right bronchus, but usually the anesthesiologist will take care to initially check the position of the tube and the cuff is inflated. So it's very, very unlikely that if the cuff has been inflated properly initially, the initial part of the surgery is fine, and in the later part of the surgery there is a sudden collapse, it is highly unlikely that the tube would have been, I can talk about extubation, But to have the tube being pushed much more than normal is a little unlikely. So when you compare B versus D, I would give first, I would say benefit a doubt to tension pneumothorax, do a X-ray, and in this case anyway the chest would be hyperresonant, the patient would be requiring a chest tube subsequently, or for that matter of fact the surgeon who's operating on the chest of this patient at the moment will have to take steps to manage the pneumothorax. Answer would be option number beta, that is tension pneumothorax for this one. Now is the standard aspect which is always asked in general medicine with respect to the JVP, and the key word of this question would be that the patient is having raised JVP with a steep X and a steep Y. I mean, this has always been asked in your FMGE exam, steep X and absent Y and steep X and steep Y. I'll just zoom it in for you. I mean, these are two statements. Out of JVP in internal medicine, what are you supposed to know? Standard things they teach in physiology also, no? Large J waves are seen in tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension, you know that. But these are two statements which I always want you to remember from the IM perspective. Steep X, steep Y and a steep X and absent Y. The explanation is given in the app for why is this happening. But at the moment, the time is for solutions. So the correct answer for this condition, I mean a steep X and a steep Y, which was asked, would be constrictive pericarditis. And anyway, pericardial effusion will be having a low voltage ECG. Pericardial effusion per se would not have any impact on the JVP because the fluid can be minimal as well. This I personally feel will be relatively easy. Coming to the next question, this has been discussed by the pathologist, but I just wanted to add my perspective on this. He talked about a gene mutation in an adolescent with behavioral issues and poor handwriting. You very well know that in Wilson disease, apart from the KF ring that you obviously can pick up, the damage to the basal ganglia of this patient can contribute to behavioral issues initially. The basal ganglia that is going to be affected in this case is the lenticular nucleus. So you could be having a dystonia and a poor handwriting coming up. The gene responsible for Wilson disease, which is the diagnosis, would be ATP7B. Somebody said ATP7A also, that is for Menkes disease, but was my students did not tell me about ATP7A, so I've not put it. And for those of you who are listening to this right now, just a bit of Q&A session. This you very well know for neurofibromatosis. This is for retinitis pigmentosa. Please comment in the chat box which disease is related to this gene, which is written here OPN1LW, or sometimes it can be OPN1SW as well. And do not go into Google browser. I know that the easiest way to solve the query that I can put up before you is just type in your Google browser and the answer would pop up. Yes guys, which disease related to the eye have you read where you read about this disease? Especially those who are going for INISET and the forthcoming exam, just checking your quick response time. Guys, this gene would be present on the X chromosome and is related to red-green color blindness. We all have read about red-green color blindness, but we usually neglect the gene. And gene is something which can be asked, I mean, any gene can be asked per se. In fact, in the Telegram group, I had discussed a list of all the genes, right? And I had requested you guys to go through at least 5 genes every day so that you never know which one might come in handy. The answer to this question is easy one, ATP7B. But yes, for forthcoming exams, I would suggest you to go through the list that I've highlighted. The next question has a surgical overlap. This is a lady who's having vomiting episodes with severe abdominal pain. Refer to the back. The moment you read abdominal pain going to the back, the first thing that comes to your mind would be pancreatitis. And then you can notice the periumbilical bruising in the patient. So the correct answer for this question straight away will answer as C. And well, why not a ruptured ectopic pregnancy? Because then he should talk about amenorrhea. At least he should describe, you know, a recently married lady and then she's having a sudden onset lower quadrant, lower left lower or right lower quadrant pain, or she's having maybe a sudden onset prostration. I mean, she just felt a sudden ache in her tummy and then she collapsed. So ectopic pregnancy, if it pops off, right, it's going to be very life-threatening, and there are going to be cues in the question related to that. Cirrhosis will anyway cause ascites. So, I mean, a couple of people said the abdomen was very wobbly and dilated, so we were thinking it could be ascites, but there would be no bruising, no. There would be no bruising present. I mean, what is shown you here is the traditional, you all know about it, you know, you read about Cullen sign and you read about a Gray Turner sign. So they just try to highlight that in an image perspective here before you. And pancreatitis, well, they can give you presence of Gray Turner, that is on when you turn the patient. No, Gray Turner, the word is turn, right? So when you turn the patient to one side, you could be having bruising. And in colon, it's around, colon has an alphabet U, so that is around the umbilicus of the patient, there would be bruising present. So answer to this question would work out to C, and the standard line, pain, abdomen, epigastric, especially referred to the back, gives you a hint. The next one talks about a patient who was brought to the hospital after a road traffic accident, and there's a evidence of raised ICP. Well, there were a couple of CT images for extradural hemorrhage which have already been discussed, so I've not included them in this particular solutions sheet that I'm discussing before you. But then the question says, in this guy with a raised ICP, what will you do? So you'll give mannitol and go for a ventriculostomy. Out of the 4 options which are given in this case, I mean, furosemide works in acute kidney injury. Furosemide works in pediatric raised ICP but does not work in internal medicine, and acetazolamide and glycerol are oral drugs, so they will be relatively slow to act. If they ask you in the exam, how do you manage raised ICP? Normal pressure hydrocephalus. Pure internal medicine question. Normal pressure hydrocephalus is where you use acetazolamide and glycerol. But when it comes to a scenario of an emergency, it's obviously mannitol, a osmotic diuretic, which will be useful. 28 has an overlap with physiology. Corticospinal tract crosses over at which level? So you very well have read about corticospinal tract also being called as a pyramid. So we call it it's called as pyramidal tract, and it traverses the pyramid, and pyramid would be present on the dorsal aspect of the lower part of the brain. That's going to be primarily the medulla. The answer to this question will work out to be option number delta. Moving to the next question, he talks about a drug in patients of asthma but is not causing a bronchodilation. Now, if you look at the discussion here, in any asthmatic or sick, you would definitely be using SABA, you will use terbutaline, and if you don't have these, you can even use adrenaline subcut, because adrenaline will also act on beta 2, no, and it will cause a bronchodilation of the patient. But why do you use hydrocortisone in an asthmatic patient during exacerbation? Is because it inhibits phospholipase A2. And if you inhibit phospholipase A2, what will you reduce the production of? You will reduce the production of leukotrienes. I'll just write the word LT4 here, because you downgrade the production of leukotrienes, which are the villains behind asthma. You would be able to control it, but per se hydrocortisone will not be having any effect on the bronchodilation component. The correct answer to question number 29 is option number D. The remaining drugs definitely are bronchodilators. Salbutamol, ipratropium is an anticholinergic drug, so it will neutralize the bronchospasm, and darifilin is a cousin of theophylline and is again a methylxanthine, which is used as a bronchodilator. Aminophylline per se, guys, nowadays the usage is not recommended. For technical details, you can listen to the asthma discussion. I mean, aminophylline can have toxicity and can cause PSVT as well, but at least it causes a bronchodilation. The next question was again a widely, hotly debated one in my group. I mean, students were literally, no sir, there was a flexion at DIP, extension at DIP. So I did a voting, and this is what I got. See, what I got was, I simply did a voting when we were discussing the paper, that what was the problem at the PIP and what was the problem at the DIP. So the majority of the students reported that at the PIP of the patient there was a flexion present, and at the DIP of the patient there was a extension present, right? It is not a flexion at the DIP. It was a flexion at the PIP and extension at the DIP of the patient. Now I will show you an image which will resolve the problem for you and is also present in the app. If you go through the rheumat section, the same image is very much there, where simultaneously I've highlighted swan neck versus boutonniere deformity of rheumatoid arthritis. So let me just put a pointer there so that it becomes clear to you. When it comes to a swan neck deformity, I'm using color green to highlight this, and you will notice this is the proximal interphalangeal joint, this is the distal interphalangeal joint. At the PIP there is a extension, extension, and at the DIP there is a flexion. Now compare this with the next diagram, where I'll be using let me say alternative color to make it easier for you. You will notice that at the PIP of the patient, this is PIP, this is going to be DIP. At the PIP of the patient, there is a distinct flexion. You can notice the flexion component. At the DIP, there is extension component. This is what I said. I mean, most guys voted in favor of that. There was a flexion followed by an extension. So that works out to be a boutonniere deformity. Comparison, mallet finger will only be having a very classical, I mean, mostly wicket keepers or goalkeepers would be having a mallet finger. So in those circumstances, there would only be a flexion at the DIP of the patient. You know, a wicket keeper or a goalkeeper, if they're taking a penalty shootout, so they have to grab onto the ball, and there can be avulsion of the extensor tendon, which could result in this manifestation. And jersey finger, which was option number D, is exactly opposite. You can notice that in mallet finger, it is the extensor tendon which is avulsed out, and in jersey figure it is the flexion tendon which is avulsed out. So if you can just go through these images, it will resolve the controversy for you. And the answer to this, I would rate it as boot and hairs based on the inputs that I got. The next question talks about a 20-year-old boy with a pain in the scrotum with red discoloration of the scrotal skin. Lot of people said this statement that I'm highlighting at the moment was not given. I am deliberately discussing this question, though I could have let the surgeon discuss this also, because I can give you two versions in the same question. My point is, the way the question is given, first line, it could be acute scrotum, that is torsion testis. But then the doctor did an examination, and when he lifted the testis of the patient, there was a relief of pain. This is what is called as prehensine. So if he asked about it, if he did not, well, your answer is fine, torsion testis is okay. But if prehensine was given, as couple of people disputed, and yes sir, this was present, then the answer would change over to epididymoarthritis. So I given you both the versions. So for future aspirants, I want you to be very clear. I mean, every acute scrotum, don't jump onto torsion testis right away. I mean, if he gives you a bell clapper deformity, and I've discussed that in the rapid revision surgery as well, so you can go through that. If he talks about a bell clapper deformity, it's a torsion testis. Otherwise, it would straight away turn out to be epididymoarthritis. 31, 32 are overlap with other subjects. So two questions I put up, which are, I would say, having a bit of overlap. So I do have the luxury of incorporating that. That's what they're trying to do, integration. This patient presented with this bullous lesions, and the moment you have this bulla, you definitely can pick up the fact that this would be relatively flaccid, and simultaneously there is a mucosal involvement. Considering that a flaccid bulla, you can see it's relatively loose, and a mucosal involvement, the answer would go in favor of pemphigus vulgaris, intense bulla, and extreme erythemata skin. Then we will think in terms of bullous pemphigoid. The antibodies for this have been discussed in the main section in the app. Coming to 33, pure internal medicine question. This talks about a person having drowsiness and irritability, and the sheer length of the question bogged people out. But I want to highlight you that even before I read this question, if you go in the app, I have discussed the CSF findings for the following situations. I have talked about acute bacterial meningitis, tubercular meningitis, subarachnoid hemorrhage, viral meningitis. And one thing that I've always said is, whenever you're gonna be having lymphocytes in an Indian exam, you always have to think first for tuberculosis. Lymphocytes can be present in both tubercular meningitis as well as viral meningitis. What will be the differentiating feature? The sugar values. But first differential in an Indian exam should always be kept for tubercular whenever they talk about a person having features of nuchal rigidity. In this question, there was a long history. He mentioned the fact that the person wants to sleep all the time. In fact, all of us want to sleep all the time if we want to be lazy, especially in lockdown time. I mean, majority what the people are doing is spending time on the internet or sleeping off. In this particular chap, there's a definitive nuchal rigidity which tells you that there is a meningeal irritation present. So the doctor did a lumbar puncture and look at what he got. 100 lymphocytes. The sugar is 54. Now sugar of the CSF is 2/3 of the blood sugar. I'll just jot it down before you. Like, let me say your blood sugar at the moment is 100. So 2/3 of 100 will work out to be 66. So I can say that for majority of us, if we had a snack or food a few hours ago, the CSF sugar of you and me would be something in the range of 66. But in this multiple choice question, you can see the values given to be 54, which is lesser. Proteins are markedly elevated. I mean, normal proteins in the CSF are 15 to 45 milligram percent. Milligram. Look at the value here, 3 gram percent. This is going to cause a cobweb coagulum. So the question is giving you a diagnosis right on that this could be tubercular meningitis, and because we are making a diagnosis of tubercular meningitis, we will be starting our patient on anti-tubercular drugs. If this question was having a normal sugar with a mildly elevated protein, I could have thought in terms of possibility of fungal meningitis. In fungal meningitis, yes, there could be lymphocytes present, but sugar would be normal to slightly low. But then fungal meningitis should be common in immunocompromised patients. In an Indian scenario, whenever you get lymphocytes with a gross, the word is gross elevation of proteins, it is tubercular etiology to be considered, which makes us consider, tubercular meningitis as first possibility and ATT drugs to be started with steroids. In the next question, he said a person is having dysentery, that's bloody diarrhea. The doctor has diagnosed it as Shigella. Obviously, Shigellosis and Shigella flexneri is common in India. And he's saying that what clinical feature would made him choose Shigella over cholera. So we are simply looking at the case definition of acute dysentery. The case definition would mainly be presence of fever. You see, it's not about rectal pain or abdominal pain, because loose motions can anyway cause abdominal pain and even a rectal pain, because if a person goes to washroom again and again, there will obviously be some discomfort in the perianal area, which the person might describe as rectal pain. So it's not about rectal pain per se, it is mainly presence of fever with blood and mucus in the stool. Now obviously he has not incorporated fever, he's not incorporated the blood or mucus in stool, because that will make it very obvious. But then in cholera we do not have any fever present. The answer to this question turns out to be option number C. It was simply the definition of dysentery that was asked, and you would be starting this patient on nalidixic acid or norfloxacin, and it would be goodbye to shigellosis. The next question talked about a 60-year-old male with low backache with sclerotic lesions in the vertebra. This is, well, what I've discussed also, the lytic lesions, bony metastasis. It could be osteolytic, osteoblastic, and most people tend to read only two of these, and they neglect the third one. Osteolytic secondaries are renal cell carcinoma. Osteoblastic is breast cancer, but when it comes to prostate cancer, breast cancer can be both osteoblastic and osteolytic, you know that. I put which is more predominant. When you read the word osteosclerotic, it's gonna be prostatic cancer. It goes via the Bateson plexus. You all have read about it. And carcinoma prostate is anyway one of the important cancers in men, leading cancers in men. So anyway has to be read up very well. The question mentioned, most guys said, sir, when we read the question low back pain, we thought previous year question multiple myeloma. But then multiple myeloma will be having the word lytic lesions. Here it was not the word lytic lesions. I confirmed that with a lot of my students. It was not lytic, it was sclerotic lesions in the vertebra, which makes the diagnosis of this case as prostate cancer. Moving to the next one. The question says, which of the following will result in development of a wing beating tremor? So very classical, wing beating tremor is a feature of copper deposition in the basal ganglia. That would be Wilson disease. So there were two questions on Wilson. One I have handled, the genetic part was asked, and second was the manifestation of it. The tremor is the wing beating tremor. Answer to 36 is C. 37 is an overlap between medicine and pathology. A female with malar rashes is having vegetations on either side of the heart valves. The moment you read malar rashes, you are thinking in terms of SLE. And because of vegetations on the either side, we are talking about the manifestations, cardiac manifestations of SLE, that is Libman-Sachs endocarditis. So the diagnosis is relatively easy. 38 was slightly a tricky one. It said a patient has been admitted to a ICU since he's having fever for past 4 days with new onset of breathlessness, which is unresponsive to incremental rates of oxygen. The key word of this MCQ is that you need to look up for a condition causing refractory hypoxia. He is mentioning the fact that the doctor is giving oxygen to the patient. You see, he's written incremental flow of oxygen was given to the patient, but saturation is still dropping. Standard presentation could have been COVID-19 pneumonia. No, in COVID-19 pneumonia, you keep on giving oxygen to the patient. SpO2 keeps on falling, and person ultimately expires due to multi-organ failure. So could be a presentation of simple COVID-19 that he could have given. But instead of writing COVID-19, he described somebody who's having a refractory hypoxia because there's a substantial lung damage. He says, what can be the diagnosis? Now, when it comes to atelectasis, the management of atelectasis would be chest physiotherapy, percussion devices, and supplemental oxygen. It responds to oxygen. Atelectasis responds to mobilization of the patient, make the patient sit up in the bed, give him supplemental oxygen. The basal lung segments will once again start getting ventilated. Idiopathic pulmonary fibrosis can be ruled out very fast because it will have a chronic presentation, whereas in this MCQ the presentation was only a past few days. IPF does not have a ICU admission and deteriorates over 4 days, it's over months. Mediastinitis is also ruled out because it will contribute to chest pain. There's no chest pain described in there's no history suggestive of mediastinitis, and more importantly, there is no chest pain present. You are left between two scenarios, atelectasis and ARDS. And where do you read this term, refractory hypoxia? You always read it for ARDS. In fact, I want to say that this question probably could have been simply a manifestation of COVID-19 pneumonia, because these patients go into ARDS and don't respond. This word you will read multiple times with me saying, or the pathologist saying, refractory hypoxia. You keep on giving oxygen because the basal lung segments are not only affected, even the upper part of the lung, middle part of the lung is also affected. See, COVID-19 will mainly contribute to lower lung segments getting involved. But once it goes into ARDS, then whole of the lung is involved. There's a non-cardiogenic pulmonary edema. The pulmonary compliance becomes substantially reduced, and that deteriorates the patient to, I would say, a bad shape, or makes the patient go into a bad shape, and ultimately person goes into multi-organ failure, because hypoxia will damage all the critical organs per se. The answer to question number 38 would be option number C. The next one says, what is the best treatment for empyema? We very well know empyema would mean pus in the pleural cavity. So you need to put in a chest tube. The best way to get rid of this pus is put in a chest tube and just get rid of this along with antibiotics. Thoracocentesis means you're putting in a needle, and with needle the pus may be very thick. It may not come out. Thoracotomy will be very invasive. I mean, you open up the chest and you try to take out the entire pus. It may not come out in a single setting. It might be loculated as well. And then you will keep on breaking the loculi. So that will make the morbidity part of the patient relatively, I would say, longer. So in most cases of empyema, if you intervene fast, if you don't intervene fast, obviously those adhesions will develop and it will become a loculated empyema, and then chest tube will not work. Then you need to do a thoracotomy. But in early cases of empyema, where there's pus in the pleural cavity, just put in a chest tube and get over with it. If this MCQ changes over to that of loculated empyema, I repeat the fact, if this MCQ himself mentioned loculated empyema, then you definitely need to go in for surgery. You need to go in for thoracotomy, break those adhesions, break those loculi. And why pleurodesis is not the answer? Because pleurodesis is done in cases of malignancies. Pleurodesis is done in malignant pleural effusion. So that's another point that they can ask you definitely. I mean, how do you handle a person with adenocarcinoma? Remember, adenocarcinoma is a peripheral lung cancer. This peripheral lung cancer will contribute to a malignant pleural effusion, and it will come back again and again and again. So how do you solve it? One solution is remove the tumor. Other solution is go for pleurodesis. Additions between the pleural two layers of the pleura will take care of the recurrent massive pleural effusion that these patients can develop. The answer to the question is C, and I've also discussed two more scenarios here. Coming to question number 40, what are features of HELLP syndrome? So hemolysis, RBCs are loaded with LDH, right? So when the RBCs will burst, it will contribute to release of lactate dehydrogenase in the circulation. We also spoke about normal values of LDH 140 to 280 international units. So this LDH will spill over, and that is why you would be having this manifestation. You definitely have low platelets here. You definitely have increased liver enzymes. So by exclusion, the answer would be delta pancytopenia. 41 talks about a person in a wheat facility having yellowish discoloration of eyes, pruritus, and weight loss. So there's definitely liver involvement, because he's talking about jaundice. Most importantly, person is having significant weight loss. So the moment you read about that, you know you're talking about a liver malignancy. He's himself telling you person is having hepatomegaly with ascites. Ascites usually develops with cancers. This person had been, in fact, he has given you the liberty of telling you that the person has developed a hepatocellular carcinoma, and is asking you one of the reasons behind it, that is aflatoxin. I mean, a person working in a wheat facility, there could definitely be exposure to this fungus Aspergillus flavus, because this grows with wheat, and this fungus produces aflatoxin B, and that contributes to hepatocellular carcinoma. And they could have made it a two-step question by saying, how will it cause a cancer? So you very well know it will inhibit apoptosis by inhibiting CD95, and when you inhibit the programmed cell death, then the cancer will obviously develop. The answer to this question is beta. In which of the following shocks is CVP increased? I mean, standard favorite question of mine. In every shock, CVP is lesser. The only shock where the CVP is going to be elevated, I mean, central venous pressure is, which you can check in intrajugular or even in the subclavian vein of the patient, preferably the subclavian vein. In all shocks, CVP is lesser, but every time the person is having a cardiogenic shock, CVP would be elevated. If the CVP of the patient is more than 10, then IV fluids are never given. And in all other types of shock, whatever be the variety of shock like hypovolemic shock or distributive shock, CVP would always be less than 10. So you would be rather on the lower limit of normal, less than 2, because normal range is 2 to 10 centimeter of water. Normal central venous pressure is, it's not JVP guys, please be clear, I've explained that in the app. Normal CVP is 2 to 10 centimeters of water. So if it's gonna be elevated, we definitely need to think in terms of cardiogenic shock for the patient. We are having this lady who's coming to you with lethargy. She's gained about 10 kgs in the past 3 months. So weight gain this time. Dry skin, hair loss, intolerance to cold. So the moment you read cold intolerance, you read about constipation, you are always thinking in terms of hypothyroidism in the patient. Pretty straightforward a manifestation. Some people said it was written Hashimoto's thyroiditis. Yes, Hashimoto's can contribute to hypothyroidism. And in fact, I think there were 2 questions on thyroid. One was on hyper and second was on the hypo part. So I've incorporated the hypo one here. And for Graves, there would be an antibody present. That would be LATS. And for Hashimoto, there would be TPO antibody, thyroid peroxidase. A patient presents with dyskinesia, rigidity, problem in substantia nigra is noted, and which is the neurotransmitter involved. So that would be straightforward. I mean, you read substantia nigra, you know that you are dealing about Parkinson's disease, and the neurotransmitter involved would be dopamine in this case. And if we talked about somebody with dementia, we could have thought in terms of acetylcholine getting affected. The next patient of mine is having fatigue, restlessness, and macrocytic anemia. There are 2 reasons for macrocytic anemia, important ones, B12 and folic acid deficiency. He has himself told you that B12 levels are normal. So what will you do next for the patient? Give this guy folic acid, no? It will resolve the macrocytic anemia of the patient. Causes of macrocytic anemia over and above this can be chronic liver disease, it could be hypothyroidism, it could be aplastic anemia. And in HEMAD, I have discussed causes of macrocytic anemia, but for this one, it would be straightforward folic acid. A patient presented with a potassium of 3.2, does it require a IV correction or does it require oral correction? If potassium is less than 3, it is IV correction. If it is 3 to 3.5, it is oral correction. I've highlighted this, guys. Please remember, if it is 3 to 3.5, it is oral correction with pot chlor. If it is less than 3, it is IV correction with potassium chloride that is required. Traditionally, they ask in the exam questions on hyperkalemia, but this time, luckily, I would say they asked rather an easy one, hypokalemia. So you would be using pot chlor in the patient. The answer to this question will work out to option number delta. The remaining options, insulin, calcium gluconate, calcium carbonate, sodium carbonate, they are the ones which would be recommended for a hyperkalemia with acidosis or hyperkalemia per se. Coming to the second last question for today, this question said a patient on digitalis develop arrhythmia. You very well know that the commonest arrhythmia with digitalis happens to be ventricular bigeminy. And for management of ventricular bigeminy, we shall be using lignocaine in the patient. This is a flowchart which is mentioned in the app, or I would say you can hand draw this even now. Every arrhythmia and the drugs are given here. And digoxin is anyway known to cause a VB. Digitalis digoxin variants cause VB, ventricular bigeminy. The treatment happens to be lignocaine for the patient. In fact, one more drug that is useful and I can add to this is phenytoin. I mean, looks surprising, but even phenytoin is useful for management of ventricular bigeminy. Very surprising. Why? Because in cardiac condition, I'm teaching a neurology drug. Phenytoin is for epilepsy, no, but phenytoin is being used in cardiology for ventricular bigeminy as well. Very straightforward question, and I would suggest you, the carry home message is the interpretation of CSF and the tachyarrhythmias. That's always asked in the exam. I mean, it's inexcusable to go to the exam without reading topic of arrhythmias, without reading Glasgow Coma Scale, ABG interpretation. I mean, these are very niche and very classical topics or aspects which are always asked. Coming to the last one, this talks about this lady who's having problems with balance while standing. So he's talking about proprioception issues in the patient, and there's loss of vibration as well. So what should be administered? So he's pointing towards demyelination of the dorsal column. The disease that he's talking about here is subacute combined demyelination of the spinal cord, a hot favorite of our examiners. The cause of that happens to be vitamin B12 deficiency. The answer will be option number C. And these are, I would say, the aspects of questions that I would like to discuss with you for this particular session. If you have any queries, you're most welcome to comment in the comment section below, and I'll be glad to assist you and help you with the if you think that there was some variation in options, whether you think that an answer should be an alternative one, just speak your mind out, and I'll be glad to assist you. And I can assure you the fact that in medicine and surgery, I've discussed around about 50, Dr. Pritesh in surgery is discussing about 60 questions. That makes it about 110. And if you get even 25, I'll just write it be very optimistic here. Guys, even if you get 25 correct in medicine, you get 25 correct in surgery, I'm very, very sure in pediatrics there were 15 questions and they were very easy. You can at least get 10 right. And OBGY, I know all of you have read very well. Whatever source that you are using, getting 25 correct in OBGY is no big deal. So how much are you getting in paper 2? What I can say at the moment is in paper 2, getting 85 is no big deal. And paper 1, guys, if you get 100, I'm being optimistic, but if you get 100, 185, you're through, man. So I would like you to not try to be idealistic, but at the same time realistic. That's the main message as far as today's discussion is concerned, because realistic expectations, realistic goals are to be achieved, and you are on your path for being a doctor in India, and you start practicing. And I'm very sure that with the kind of inputs that I've had from all of you, when the results would be coming, all of you would be having very fantastic results. My message to your juniors is that do not leave any subject. Just go through all the subjects. Be a jack of all trades. Just be average in all. You can go through my YouTube channel as well, and I've posted a couple of revision videos, some very baseline data. That's the basic minimum is expected out of you. See, you tend to build over a base. That's the baseline data that I want you to be aware of. So just scroll through those videos, go through those videos, so that at least you get an idea of what is being asked. And once you are done at that baseline level, then you keep on building over and above this, because Rome was not built in a day. Similarly, your career will take some time, and I'm very sure all of you would come out with flying colors. Thank you for your patience and hearing me out.